Please.
Yes. A very warm good morning to one and all present here today to celebrate World Pre-eclampsia Day 2022 in association with IRIA Samrakshan and IRIA Preventive Radiology. Today, I am really honored to invite Dr. Rijo Matthew, IRIA Kerala, to give the inaugural address.
Soumya, thank you, Soumya, but I'm not going to give the inaugural address. We have got a chief guest here. It's welcoming everyone is my job. So once again, welcome each one of you who have joined for this special session starting today on behalf of on World Pre-eclampsia Day. And we will be having a series of webinars starting today for the next till May 28th. As most of you are aware that India has a high maternal mortality rate and a high perinatal rate, which India contributes to nearly 25% of all the perinatal if you look at all the perinatal statistics, all the maternal statistics, India contributes to nearly 25% of them. So Samrakshan, a project that was initiated by Indian Radiological and Imaging Association to reduce the perinatal mortality and to apply the principles of preventive radiology and the radiologist's role using technology to accelerate this process has been in progress for the last 3 to 4 years and has made considerable progress and interest all over the country amongst all the major stakeholders in pregnancy and childcare and in childbirth in India. So on behalf of the IRA Samrakshan Committee and the IRA Preventive Radiology Committee and IRA's Kerala State Chapter, I welcome each one of you who have joined here for this World Pre-eclampsia Day webinar, which will have two very interesting talks on by Dr. Bimal Saini and Dr. Praveen Nirmalan on the various aspects of preeclampsia and fetal growth restriction. To inaugurate this session, we are extremely honored and privileged to have the president of the Asia-Oceanian Society of Radiology, the chair of the RSA, and she has been doing a pioneering work in the field of radiology in the Asia-Oceanian region. I have the pleasure to introduce and welcome our chief guest today, Dr. Evelyn Ho Laming. She is a consultant clinical radiologist at Park City Medical Center, Kuala Lumpur, Malaysia. And she is the president of the Asian Oceanian Society of Radiology, serving on the AOSR Council from 2008 and chair of the Radiological Society of North America's Regional Committee for Asia and Oceania. She is the fellow of the Academy of Medicine of Malaysia, honorary fellow of the Academy of Medicine of Singapore, and as an honorary membership of the Chinese Society of Radiology. Evelyn's healthcare and community contributions have spanned over 20 years with innumerable public health talks and webinars on various topics related to her breast health campaigns for nearly 10 years. She authored a booklet on the art of being breast aware. In 2005, Evelyn received the Novartis Malaysian Breast Cancer Council Leadership Award in Breast Cancer Advocacy. Apart from this, my personal interactions with her as part of the QSS committee, she has been taken a lead role in promoting MR safety in our Asia-Oceanian region. Her past leadership roles in the College of Radiology Academy of Medicine of Malaysia, as the council member, as its secretary, and the AMM council member, the bursar of the AMM, and she pioneered and hemmed the Malaysian College of Radiology AMM website from its inception in 2001 till 2014, and ran the College of Radiology of Malaysia subsidized value-added mammogram programs. She sat on the Malaysian National Credentialing Committee from 2009 to 2010 and was secretary-treasurer of the ASEAN Association of Radiology from 2004 to 2006. Her areas of interest in radiology include breast radiology, ultrasound, and general radiology. She's a reviewer for Malaysian medical journals. Evelyn authored a chapter, Bridging the Radiological Healthcare Divide with Social Entrepreneurship, in the book, Radiological Safety and Quality in Radiology, Paradigms in Leadership and Innovation. So this is Dr. Evelyn Ho Laming, and we are Extremely honored and privileged to have you here on this World Pre-eclampsia Day to inaugurate this session and to give us a message. With that introduction, may I welcome and invite Dr. Evelyn Ho Laming, the President of Asian Oceanian Society of Radiology. Over to you.
Hello, thank you very much, Rijo, for that extremely generous introduction. Salam sejahtera, as we would say in Malaysia, and greetings from the AOSR. Today is World Pre-eclampsia Day, an effort to mobilize worldwide awareness over early detection of pre-eclampsia to avoid culmination in eclampsia that could have serious morbidity and even mortality on mother and unborn baby. Pre-eclampsia occurs uniquely in up to 8% of pregnancies worldwide. Family history of pre-eclampsia, autoimmune conditions, history of hypertension, kidney disease or diabetes, as well as obesity could put someone at risk for pre-eclampsia. For the pre-eclampsia survivors, they are at 2 to 10 times the risk for cardiovascular disease, including stroke, and 4 times more likely to have high blood pressure. It is no wonder then that there are pre-eclampsia survivor support groups out there. In the past, pre-eclampsia has been more a clinical diagnosis. Pregnancies presenting after 20 weeks with high blood pressure, proteinuria, edema, headaches, blurred vision. So how does radiology come in? I heartily congratulate IRIA through Samrakshan and Preventive Radiology and today's other associated organizer, JournoMed and MedPiper Technologies, for establishing the World Pre-eclampsia Week series of webinars from today until the 28th of May. In most hospitals or centers in the world, fetal sonography has become the realm of the obstetrician and the gynecologist. This is where I'm delighted to see in India, there is fetal radiology, championed by radiologists. I am particularly proud to have as colleague and friend Dr. Rijo Matthew, who is deeply involved in fetal radiology to bring about a change in maternal and fetal mortality. To all of you involved in fetal radiology and the multidisciplinary team, kudos to all of you. Samrakshan being the national program of the IRIA to address the high rates of perinatal mortality, low birth weight, and preterm babies in India is a stellar example of how radiology can bring about a change in maternal and fetal mortality to all those involved in bringing radiology out from the dark room. So this is how India is a stellar example of doing this. Leading the way nationwide on how to use ultrasound and Doppler studies and other biomarkers in imaging combined with clinical features and biochemistry will ensure radiology contributes to national and worldwide healthcare in a meaningful way. Congratulations is also due for the paper that was published, Reducing Perinatal Mortality in India, 2-year result of the IRIA Fetal Radiology Samrakshan Program. I hear that this publication, presenting the results of early identification and risk stratification of pregnant women at high risk for developing pre-eclampsia and fetal growth retardation, has garnered international attention. This impactful initiative from India, with evidence accrued and peer-reviewed, could eventually be extended to other countries, especially low-resource countries. We look forward to building alliances for the same cause, a safe motherhood effort. Our solutions, of course, will have to be resource stratified and practicable. Just before I sign off on this message, permit me to mention one of the other initiatives of the AOSR. The first one was the MR Safety Initiative that Dr. Rijo mentioned. It is ongoing, and IRIA also participated with your own Indian Awareness Program in October 2021. In addition, the AOSR is committed to value-based radiology, as this will ensure we move with the times and continue to be an integral part of the medical world, if not an indispensable part of the multidisciplinary team. Therefore, if you receive a link for the AOSR value-based radiology survey, please participate in this. Every center is encouraged to participate, and this is a survey to bring awareness, as well as to give the AOSR some idea where we are, what we need to do to enable all in our community to be valuable members of the healthcare team. I hope the IRIA, as an integral member society of AOSR, will help to promote this survey through the whole of India and to its neighbors through personal and official networks. Today, it's proof that India practices value-based radiology in the arena of maternal and child health, bringing the relatively invisible dimension of radiology amongst the major stakeholders into the forefront. Congratulations to the organizers for leading the way in pregnancy care and fetal radiology. You have indeed proven that radiologists can indeed guide pregnancy care for better outcomes. Thank you very much for inviting me to inaugurate this kickoff session, the first in a week of webinars.
Thank you, Dr. Evelyn Ho, for the inaugural address and the message on the World Pre-eclampsia Day. Thank you once again. We are honored and privileged to have you here. So we will now move on to the academic session. Let me introduce the National Coordinator of IRIA Samrakshan Project 2022, Dr. Shilpa Satarkar, to take over the academic session. We have got two talks, very interesting talks by two eminent speakers, and the various aspects of preeclampsia, fetal growth restriction, samrakshan, and the research in our country. So they will be talking to us and enlightening us on the various aspects which will give us rare insights into the future, and also will help us guide our action plans better to reduce preeclampsia in our country. Dr. Shilpa Satarkar, please.
Thank you, Dr. Ijo sir. Welcome all to this full week celebration of the pre-eclampsia month. So today is the World Pre-eclampsia Day, and from today onwards, we are starting 1 week webinar series on pre-eclampsia and various complications and things related to pre-eclampsia. So on first of this talk will be taken by Dr. Bimal Sahani. Bimal Sahani sir, he is from Aurangabad, my teacher from Government Medical College. Right now, sir is director of the Sonoscan Center at Aurangabad. He is a national president of the Society of Fetal Medicine, who works on the same aim of having a maternal and a fetal care. He's also academic coordinator of the Scholar MD Fetal Medicine Training Program for Radiologists. It's a premier institute with all radiology teachers teaching radiologists to get at par with the fetus, and I'm proud to say that I'm also alumni of the same training program. And sir is from Government Medical College Aurangabad. Apart from his academics thing, as a person also, he's absolutely wonderful. You can say a guide, a teacher, and friend. Every aspect of sir is absolutely wonderful to have with. Considering his publications and presentations, he has authored the second trimester guidelines of the Society of Fetal Medicine, and then he's also co-author for the SFM India oriented guideline statement of the COVID-19 pandemics. He has also various presentations in national and international conferences, and his area of interest is fetal growth and the fetal echocardiography. So today, sir will tell us about how preeclampsia is going to affect the fetus and the early FGR, how these are coordinated, how we are going to identify these things. Over to you, Bimal sir.
Thank you very much, Shilpa, for those kind words of introduction, and I think a very, very motivating talk by Dr. Evelyn right in the beginning has set the tone for this week. And I think, so well begun is half done. And so I really wish this whole week, at the end is very, very fruitful, where people log in, people learn something new, and most important thing, they put it into practice from the very next day. Now, when they say pre-eclampsia and FGR, very honestly speaking, I was thinking of having two different presentations on that, and trying to merge both of them. Now, women with FGR, 15% of them develop pre-eclampsia. Now, you can have pre-eclampsia with FGR, you can have pre-eclampsia without FGR also, but pre-eclampsia with FGR is a serious condition. It has higher morbidity for the mother. All these HELP syndromes, cesarean section, there is a higher rate. And as far as neonatal outcomes are also concerned, if you take FGR without preeclampsia and FGR with preeclampsia, the neonatal outcomes are worse when it comes to FGR with preeclampsia. See, if you look at the pathophysiology, eventually everything comes off to be nearly the same. Everything is happening at the placental level. So there is a definite interlink between the two. Now, I'm not going to get into the definition and the management of preeclampsia, because that is something which is the domain of the obstetricians. Now, Dr. Evelyn said that, yes, she's very happy that, radiologists are taking part in even, screening for pre-eclampsia all over the world. Yes, now it has gone to the obstetricians. But I think the magnitude of the problem is so strong in our country that, it doesn't matter who's doing it. As long as, see, the final aim of all of us being doctors is to give every mother a safe motherhood and every fetus an optimal outcome. And for that, it doesn't matter whether, the obstetricians are doing it. If they are not doing it, we will do it. See, the patient, radiologists are a part and parcel of the management team for pregnancy. See, we have ourselves put us as just imaging people, that we are not technicians. I'm not just going to do the uterine artery Doppler and say the PI is more and leave it on somebody else to interpret what to do about it. No, that a sonographer can also do. But I am a qualified doctor. I need to take a call. I need to interpret the reports. Yes, the patient is with me. It doesn't take much time. Yes, with a little extra time, I can go ahead, take the history of the patient. I can, if the map has not been done before, or I will do that. And the softwares have made life so easy. I put everything on a software and I'm going to get what is the risk of pre-eclampsia. See, there are 10 million women around the world develop pre-eclampsia. If you look at these figures, that is the time when we really start thinking. 76,000 pregnant women die each year from pre-eclampsia and other hypertension disorders globally. So, indirectly what I'm trying to say is that every 7 minutes, one woman loses her life. So if by the time I finish this lecture, there would be another 6 to 7 women who would have died because of pregnancy related, hypertension related disorders. On the other side, because of this, the impact of hypertension on the fetus, there are 5 lakh babies die from pre-eclampsia and other hypertension disorders annually. So 2.5 million preterm births. And now when I say preterm birth, okay, it's not just about giving a live baby to the parents. It is also what is their short-term and their long-term outcomes. That also we need to take care of. Now, if you look at the characteristics, if you look at, yes, what are the risk factors? Now, we see, I'm quickly going to take you through maternal age, because I'm talking about India. Maternal age, yes, maternal age of pregnancy is increasing day by day. Indian women are more into their career prospects now. So there was a time, but by the time the woman was 23, 24, her family was complete. But now women are getting married at around 28, 29 years of age, and then they're coming for their first pregnancy at around 31, 32, and maybe for the second pregnancy at about 35 years of age. Parity, yes, that is an important factor. Previous history of pre-eclampsia, inter-pregnancy intervals definitely are increasing. ART pregnancies, we all know that the incidence of prevalence of infertility is very high, and we are using ART left and right. So, every nook and corner you find one IVF center which is cropping up. And so we have a very high incidence of ART pregnancies. Now, family history of pre-eclampsia is important. Obesity in India amongst women is on the rise. And if, South Asian, in fact, this is considered, if you are a South Asian, you are already, you fall into the risk factor category. And then with comorbidities, again, we have a high incidence of diabetes mellitus, we have a high incidence of hypertension. So in short, the message that I'm trying to give is that, even all the radiologists and all the obstetricians and even the neonatologists, everyone gets involved into this particular aspect. Even then the people will fall short, because, and we produce nearly 30 million babies a year, 30 million pregnancies a year. So, we want everyone, and I think that is the way. And I really, my hats off to Dr. Rijo Matthews and his complete team with Shilpa now taking over that that they have come up with Samrakshan, and I can see the change that Samrakshan has made in the last 1.5 to 2 years. Now, do we need algorithms for screening? Yeah, so for me as a radiologist, I'm going to speak about the screening aspect, and I want every radiologist who's present here today to take this up seriously. So the advantage of screening is it gives me a personalized risk estimate, and you can definitely, if you follow there are different protocols, and if you follow the top end protocol, you can actually you can have a detection rate of 97.5 to 99.8% of pregnancies. And this, why all this we want, because we can start aspirin, and the aspirin trial has already shown us that yes, the use of aspirin 150 milligram at night is definitely gone a long way. In about 60 to 80% of the cases, the incidence of preeclampsia has reduced. Early onset preeclampsia has got postponed to late onset, and even has a strong effect on FGR also. So, and then these algorithms help us to evaluate new preventive therapies also. Now, what are the factors that we take into consideration for screening? Maternal characteristics, uterine artery Doppler, mean arterial pressure, and biochemistry, that is the PAPA and the PLGF. I'm not talking about the SFLT yet, because SFLT, is still under, it's still under trials. We really don't have many labs doing it yet. So, that is something we will come forward later on. Now, the maternal characteristics. So what all you need to look for. So it is a simple thing. If you, as a radiologist also, if you just have a height chart and a weighing machine, you can have that. Just you can train somebody to take down the history, the race, the parity. And these are so many things in the first trimester. When a patient is coming to you for an NT scan or a screening for aneuploidy, you are already taking most of these questions. So, you're asking these questions to the family beforehand, and then ask for history of chronic hypertension and diabetes mellitus or SLE, and measurements of the MAP is a very, very important issue here. And I think that is where things are going wrong. The radiologists in their practice do not want to take this up, because on a general, they use a sphygmomanometer for measuring the blood pressure only in cases of emergencies. And that too, I think a lot of centers would probably not have a BP apparatus also, especially the ultrasound ones, because they are not the ones who are really using that. So, but, and it looks very difficult here, because there is a lot of criteria that is given, but nothing. It is just that you have to make the mother comfortable. She should be sitting comfortably, and you should measure the BP at the level of the heart. The legs should be uncrossed. The cuff size should be selected. These are all things which are routine, which we have learned in our MBBS thing. So I think the most difficult part is that neither the observer nor the patient should talk for 5 minutes. Now that keeping a woman quiet for 5 minutes becomes a little difficult, and that would probably increase her anxiety. So I do allow them to see a little bit of their WhatsApp, so that they are quite comfortable with that. And then you measure the BP in both arms simultaneously, and the MAP is diastolic blood pressure plus systolic BP minus diastolic BP upon 3. Now, honestly speaking, you don't have to do all these calculations also if you're using the softwares there. And then uterine artery Doppler is something which we are doing as a routine in the first trimester. So there's nothing new about it. Yes, you take that and you take a mean. Now we used to use 95th centile. That there is current evidence which comes that in the first trimester we need to use the 90th centile as the cutoff to calling it as an increased mean uterine artery PI. And with a false positive rate of 8%, the detection rate for early onset preeclampsia with uterine artery is about 48%. Not that great as such. And then the biochemical markers. Not going into the details of that, but there are two biochemical markers that we take use of, the PLGF and the PAPA. Now, PLGF by itself also has a decent detection rate, but PAPA isolated does not give you a very high detection rate as such. So what would be the ideal protocol for first trimester screening? Yes, you have published algorithms. There are so many algorithms. You have the NICE, the ALCOG, and the FMF ones. And I think the FMF ones is easy to accept because of the availability of a free software, and hence we need to take it. And then you convert the values of the MAP, the PLGF, the uterine artery PI, the PAPA into MOMS. Again, you are not going to do that. The software will do it for you. And high risk is greater than 1 in 100 based on the first trimester combined test. It is recommended that for Indians, we can use the cutoff of 1 in 150 because our incidence is very high. And this risk calculator is available free of charge. So now if you look at this particular chart, you will find that if you use maternal factors alone, the detection rate with a false positive rate of 10%, the detection rate for pre-eclampsia before 34 weeks is 58%. Now, overall, the detection rate for pre-eclampsia as well as FGR for early onset is always higher than for late onset ones. Then, but if you use the maternal factors plus MAP, then this detection rate will go to 65%. I'm specifically talking about less than 34 weeks because that is the place where the decision making and everything becomes difficult because you are the prematurity also becomes an issue. And then if you add this with uterine artery PI, the detection rate goes to 80%. And if you add PLGF along with the MAP and uterine artery, the detection rate goes to about 90%. So where not possible, then you can only use by the maternal factors and the MAP. No problem with that. But you always have to remember that when more the number of markers that you take, the detection rate is going to high. So what is important is, depending upon the institute that you work, the kind of resources that is available, you have to decide what would be the best screening strategy that can be adopted there. So simple approach is go onto the software, go to the FMF Fetal Medicine Foundation, go to the 11 to 14 weeks pre-eclampsia risk. You put in the singleton, the CRL, and put in the history, whatever, whether there is a history of diabetes, diabetes 2, chronic hypertension, the origin, the racial origin is important, and then whether the mother of the patient had pre-eclampsia. So the mean arterial pressure, the uterine artery PI mean, the date of, and then whatever you are not using, suppose you have not done a PLGF, say no, and this would eventually give you that the pre-eclampsia risk from history only is 1 in 105, but pre-eclampsia risk from history plus MAP plus uterine artery PI is 1 in 141. So the risk changes. So your something which is low risk just based on history may become high risk, and you would be able to start aspirin in that patient. And somebody with a high risk may actually turn out to be a low risk by using multiple factors there. And so high risk, we start aspirin. Low risk, yes, again, assessment of risk for preeclampsia at 22 weeks is the way forward to that. And just one few seconds on the serum soluble FMS like tyrosine kinase 1. I always write this down on the slide because it's very difficult for me to remember and say this full name. But you can just say the SFLT. Now the SFLT1 PLGF ratio is something which can be used in the second trimester, and the cutoff is 38 for suspicion of preeclampsia and 85 for diagnosis of preeclampsia. But okay, as of today, let us not get into that. Let us just think about the first trimester screening with the maternal factors and the MAP, and add on with that uterine artery PI, and if the patient can afford, then add on the PLGF. So the whole essence of screening is that you can start aspirin. And the ASPIR trial has shown that if you give 150 milligram of aspirin, it should be given at night, and it should be started as early as possible before 16 weeks. It definitely reduces the maternal and fetal morbidity. And even if you start, even if you eventually diagnose after 16 weeks, you can still start that. Maybe not to that extent, but it may still help the patient, maybe postpone the development of preeclampsia later. So maternal history and blood pressure remain the cornerstone of screening. So the cheapest thing gives you the most important information, increasing evidence to improve prediction with biochemical markers. Addition of PLGF and uterine artery Doppler in the first trimester improves the detection rate, and SLFT PLGF ratio, I don't want, there is still not enough evidence for that. So I end off with the first part of my talk by, with this slide, an aspirin a day. It can make wonders. And for starting this, you need to do a little bit of extra work when you're doing your first trimester scan. And if you can do that and come up with a detection rate, I got some wonderful, I was listening to Dr. Shilpa Satarkar yesterday in one of her talks, and she came up with a wonderful, she gave a wonderful statistics there that there are 24 lakh women who are at risk for pre-eclampsia in India every year. And if you have a detection rate of 80% with the MAP and uterine artery and maternal factors, then you would be able to detect about 20 lakh women. And if you start aspirin to that, and if aspirin is effective in about 60 to 80%, then you are going to help about 12 to 16 lakh Indian pregnant women from, and at the same time, an equal number of fetuses. So friends, you don't think that you're an imaging person. Yes, you are an imaging person, but imaging is the cornerstone of fetal medicine, and hence all radiologists, if you just extend your a little bit towards the clinical side, you would probably be the best fetal medicine specialist in the world. Then, is this equally effective for screening for FGR? No. The prediction is not as good for FGR as it is for pre-eclampsia. You will have detection rate of about 12 to 47%. Now, of course, this study, these older studies, they have taken even SGAs, everything was included as FGR. But if you go by the correct definition of FGR and you use the angiogenetic markers, you will find that the detection rate can go to about 67%. But it is more for early onset FGR as compared to the late onset FGR. Now, FGR, do we need to address this issue? See, there is no meaning in this question. Yes, we need to address this issue. We know that there is an increased perinatal mortality and morbidity. We know these babies have long-term age. We know there is no management. The only management that is available is getting this baby out at the right time, neither too premature nor too hypoxic, and definitely not acidotic. So that is the aim that we have. So now you look at this particular chart, you will find in India, the prevalence of T21 is on the left side of my left side, and the incidence of severe FGR is on my right side. Now look, if you look at these, you will find, and the amount of time and energy and money we are putting in screening for the Down syndrome, and how much time do we really put for really screening for the FGR, and even pre-eclampsia also. The early pre-eclampsia, the incidence is much higher. So somewhere down the, everything is important, but somewhere down the line, I think we need to divert our energies based on what is more prevalent in our country. Now, there are two things, SGA and FGR. The definition of SGA is very, very clear because it is just a statistical deviation from normal. It says that any fetus with an estimated fetal weight less than 10 centile is SGA. But is every small fetus FGR? The answer is no. Every small fetus less than 10 centile is not FGR. 70% of them are actually normal small fetuses. Not 75, it is 70% of them are normal small fetuses. Though they are constitutionally small, the 30% of them actually are FGR. Out of that, 10% are because of the fetal factors, because of chromosomal abnormalities, infections, and 20% are because of the uteroplacental insufficiency. So the definition of FGR means a fetus with an estimated fetal weight less than 10 centile on ultrasound, that because of a pathologic process has not attain its biologically determined growth potential. So it's not just estimated fetal weight less than 10 centile, but estimated fetal weight which is less than 10 centile, which because of a pathologic process has not attained its biologically determined growth potential. Now, how do we determine the growth potential? Because that is a concept which is difficult to gauge. Hence, what we are actually doing is we are using the fetal size as a proxy. Though that is not the, that is not the ideal situation, but it is very difficult for me to gauge what is the genetic potential of every fetus. So what we are actually doing is we are using the size as a proxy. We know it has its limitations, but at the moment, that is the best thing that we have. Now, SGA versus FGR. So we just saw that all SGA fetuses, are they FGR? We said no. But are all FGR fetuses SGA? The answer is also no. All yes, in late onset, you may not necessarily have a fetus which is SGA or with a fetal weight less than 10 centile, but that could still have fetal growth restriction. But that is not my topic today. So that is a concept which is different. But for today's topic, because I'm speaking on early onset FGR, let me tell you that all early onset FGR fetuses are SGA. So that is an advantage as far as diagnosis is concerned. So estimated fetal weight less than 10 centile. If you have a uterine artery Doppler which is abnormal, or a CPR less than 5th centile, or an umbilical artery PI which is greater than 95th centile, then you call it as FGR. And or the Doppler is the normal, but the fetal weight is less than the 3rd centile, that also will fall into FGR. But if you have fetal weight which is between the 3rd and the 10th centile, and if you have normal Dopplers, then we call it as SGA. But do we leave it at that? No. I will not just say, okay, this is SGA and forget about it, but I will still keep them under surveillance, because an SGA may also eventually become an FGR later on, may start showing Doppler. But the frequency, the surveillance frequency would be different. So now for early onset and late onset, now we have a decent consensus on that, let us use 32 weeks as a cutoff. Diagnosis done before 32 weeks, we call it as early onset. Diagnosis done after 32 weeks, we call it as late onset FGR. So we can say that the inability of the fetus to reach its growth potential diagnosed before 32 weeks of gestation is early onset FGR. Now, the ESOG practice guidelines have come up with the criteria for defining early onset FGR, and the solitary criteria are: if you have an AC or an estimated fetal weight less than the 3rd centile, you can call it as FGR, or you have an umbilical artery which is showing an absent end diastolic flow, then also you can call it straight away as FGR. But for contributory factors, you have an AC or estimated fetal weight less than 10 centile, but along with that, either you have a uterine artery PI which is abnormal or an umbilical artery PI which is abnormal, you will call it as FGR, early onset FGR. So, practically speaking, the same things, but they've got it more into a specific consensus, which actually has come from the Delphi consensus there. But early onset FGR not necessarily is always placental maternal cause. Dr. Shilpa, please let me know when my time is getting over, because I can just go on speaking on FGR but so please just give me a 10 minutes warning and I'll speed up the things.
Yes, sir.
Yeah, and placental maternal cause, that is what we have been talking about, and that is where we use Doppler. But early onset FGR, you have to think of other things also. Think of genetic cause. There could be chromosomal microdeletions, duplications, structural anomalies can also lead to FGR, or congenital infections, cytomegalo, Zika virus, exposure to some drugs, toxins, alcohol, all these things can also lead to an early onset FGR. And so that also needs to be taken into consideration. And now just let us try to understand the hemodynamics of early onset FGR. What is actually taking place? See, once you understand this particular thing, that means you have understood the cascade of events that we get. And if you understand that, the decision making on when to deliver becomes very, very easy. Now, in early onset FGR, the placental disease is severe. So you have more than 30% placenta which is damaged. So the placental disease is severe, and in majority of the cases, not always, but in majority of the cases, you will find that the uterine artery PI is more than the 95th centile. And then now, because of the placental disease, the perfusion is going to be less, and that will eventually get reflected in the umbilical artery, and hence the umbilical artery PI will increase. And usually the CPR being more sensitive, the CPR becomes abnormal a little before the umbilical artery PI also crosses the 95th centile. So you have an umbilical artery PI which becomes more than 95th centile, and then because there is a high resistance flow, there is less amount of nutrition which is going, you have the brain sparing thing taking place, so there is more amount of flow which is going towards the brain, and you have an MCA PI which is less than the 5th centile. Now, as the peripheral vascular resistance keeps increasing, you may have a stage where you have an absent end diastolic flow in an umbilical artery, and you may also have a stage where you have a reversal of end diastolic flow. But before that, let us think of something else. Now, what is happening here is these fetuses are small fetuses. You have 26 weeks, 27 weeks. These fetuses can tolerate hypoxia for a very long period of time. They can tolerate hypoxia for a long period of time. And in early onset, generally it is the nutrition which primarily gets more affected, and hence you have an SGA. You will always have an SGA there. Now, because these fetuses can tolerate hypoxia for a long period of time, the heart gets more time to function. The heart has to pump more blood against the high resistance. And so there is enough time for the heart to keep pumping more and more blood. But then what happens is, because the heart is working so much, eventually it starts having an effect on the cardiac function, and that eventually gets reflected in the ductus venosus, which you find that the ductus venosus PI which increases. And so this stage is a stage of cardiovascular adaptation that is taking place. And then you have a ductus venosus PI which is more than 95th centile. You get you can have an absent ductus venosus PI. You will have reversal of A wave in the ductus venosus. You can have abnormal, that would lead to an abnormal biophysical profile, the CTG deceleration, and eventually, if still the pregnancy is continued, the fetus is going to die. So, this is a stage where you have a ductus venosus PI which is greater than 95th centile. After that, you start getting into a stage of severe acidosis. Then we don't want to go into that stage of severe acidosis. So that is why the ductus venosus is a very, very important vessel as far as early onset FGR is concerned. Now, decision making in early onset FGR and management, yes, you have the fetal blood sampling. We don't do NST, CTG. They have their own limitations. Computerized CTG, excellent thing. We don't have it in India, 1 or 2 places. Biophysical profile, again, has limitations, has important role in late onset FGR. So eventually we are left with color Doppler. So again, that is where the radiologists come in. So we have something in our domain. And so we just don't need to do the Dopplers and give the waveforms and give the PI to the crowd. We need to interpret it ourselves, and we need to give our suggestions on that. Now, the ISWA guidelines actually, tell you that once it is more than 26 weeks, and if you have a biophysical score which is less than 4, and see, they have used the CTG more, if there is a spontaneous persistent FHR deceleration after 26 weeks, you just have to deliver. But between 26 to 28 weeks, 6 days, you have a reversal of DV A wave, STV. So, these are all, because they have used so much of an STV, I will tell you a more simplified method, and that is the stage-based protocols from Barcelona. Actually, they are telling you the same thing in a more simplified way. They're easy to follow protocols, and because you have an app, you can just put in the findings, and that helps you. So we will go through the Barcelona staging. So they have divided the FGR with Doppler changes into 4 stages. The stage 1 is the stage of mild placental disease or severe smallness. So if you have a fetal weight less than 3rd centile or less than 10th centile with any of these factors, then it is stage 1. But now they have removed umbilical artery and MCA from it, and they've just put CPR because the CPR becomes abnormal before these become abnormal. Then stage 2 is the stage of severe placental disease. You have an absent end-diastolic flow in umbilical artery or an aortic isthmus reversal. Again, very debatable whether we should use aortic isthmus or not. I can speak from on both the sides for it and against it, but maybe we leave it for some other day. So as of today, let's say that, okay, absent end-diastolic flow in umbilical artery is, stage 2, and stage of 3 is stage of early acidosis, where you'll have reversal of end-diastolic flow in umbilical artery, or you have a DVPI, which is greater than 95th centile, and stage 4, reversal of A-wave in ductus venosus, or abnormal computerized CTG, or you have a biphysical profile which is less than 4. They would all actually suggest that there is severe acidosis there. Now,
so sorry to disturb you. As you said, last 10 minutes, I need to inform you. So last 10 minutes.
Yeah. I'll just
thank you.
Cover up with this and let you know, finish off. So the risk of, the decision making is based upon, you just have to decide what is more dangerous for the fetus at this moment. Is it to, is the prematurity more dangerous, or the hypoxia is more dangerous? And so, because every day the fetus spends in utero before 28 weeks, the morbidity reduces by 2%. And between 28 to 32 weeks, every day the fetus spends in utero, the morbidity reduces by 1%. So the whole issue is that I want the fetus to remain in utero as long as possible, but at the same time, I don't want the fetus to go into acidosis. So that is where, a simple story is, just imagine yourself on a building. You are in a building, a high riser, and the building has caught fire. The fire is coming from down. Each floor is the gestational age, the fire is the hypoxia or acidosis, and the safety net is the NICU. Now, whether you will jump or you will not jump will depend upon 2 things. What floor are you on, and how severe is the fire? So again, I'm left with the same thing, whether, what is the gestational age and how severe is the, how severe are the Doppler findings for me. Now, if I am on the 14th floor and I see that the fire is mild, okay, it is up to the 4th or 5th floor, will I jump? No, because if I jump from the 14th floor, my chances of dying anyway are much higher. And so, and I'm checking, I'm not leaving it. I'm seeing that the fire is not, it's still far away. So let me go down. There is no escalator because of fire. So I start climbing down one floor, but every floor I climb down, I check outside the window how far the fire has reached. Now, if I'm on the 12th floor, the fire has reached the 7th floor, I still don't want to jump. My risk is more. So what I do is I still start climbing down. And if I reach the 10th floor and the fire has reached the 9th floor, yes, now this fire is more dangerous. If I don't jump, anyway, I'm going to die. So better thing is I jump. I believe on the safety net, on the fire brigade team there, which is holding the safety net, the NICU. Yes, I may have some problems, but I would still survive. And there is a good chance that, maybe I don't have too much of problems. I could still have, very, very little postnatal problems there. But suppose I'm just on the 3rd floor and there is a mild fire. I don't want to take that chance because I don't know what is the speed with which the fire is going to come. And that is the reason once I'm on the third floor, then I will jump. That's okay. Maybe a little scratch here and there, but I'm sure I'm not going to have a lot of problems because of that. And so if you're on the 37th floor, you should take a call. So that is on the 37 weeks, 38 weeks, you're closer to the ground, you need to take a call. So stage 1, 37 weeks, you deliver. And if it is not 37 weeks, you monitor it weekly. Stage 2, 34 weeks, deliver. Otherwise, monitor it bi-weekly. Stage 3, 30 weeks, deliver. Otherwise, monitor it 1 to 2 days. Now, even the ISWAC protocol says that, okay, if it is stage 2, even 32 weeks, you can deliver. Stage 4, 26 weeks, you have to take a call. There is no chance because it's already severe acidosis. Then there is reversal of A wave in ductus venosus. I'm going to take a call and deliver there. And this is the beautiful chart from Barcelona, which we all should have. This gives you all the criteria, all the stages, and even the mode of delivery, and at what gestational age you should deliver and how you should monitor. And if you just use this and in fact guide your obstetricians, you can actually become a part and parcel in the decision-making team there. Now, there is one more important thing. Now, once you see an umbilical artery which is abnormal, if you see it before 26 weeks, then the placental disease is definitely severe, and you are going to get the critical Doppler abnormality usually less than 29 weeks. If you find abnormality in the umbilical artery less than 29 weeks, then by 33 weeks, you get severe Doppler abnormalities. And if you do it before 31 weeks, if you get it by 35 weeks, you get. Now, this is just, this is a rough estimate of things. This helps you in counseling the parents that, yes, probably we can push on, we'll try. And, but yes, this is not really going to go too far, but, we need to do quicker monitoring. So in early onset FGR management, identify a small fetus, do Doppler, distinguish between FGR and constitutionally small fetus, rule out fetal causes, stage the FGR and plan surveillance, and then decide on when to deliver. An objective protocol-based approach to decision-making is now validated, and ductus venosus evaluation is the cornerstone for assessing when to deliver in early onset FGR. That becomes a very important thing. I actually had a few cases, but I'm short of time. I will take you through only one case. Early pregnancy, 8 weeks, dates were corrected. 19 weeks, 5 days, you have this kind of AC, which is less than the first centile. Fetal weight is at the third centile. The question in my mind is, yes, is this FGR? The dates have been corrected. Yes, anyway, by definition, also it's FGR. Do I need more information? Yes. I saw the FTS, uterine evaluation was not done. Presently, no structural anomalies, no soft markers, but the Dopplers are showing an increased mean uterine artery PI and an umbilical artery PI, which is more than the 95th centile. Now the question is, yes, this is stage 1, that is not a problem. Any other investigations? Yes, I would actually want for genetic evaluation and infection, the torch also. Then patient may opt for termination because there is so much of a growth restriction which is occurring there. So we need to give them all these information. Yes, this may end up, but we need to go to at least 26 to 28 weeks. So all this information is to provide it. And when would you like to follow up? Now, if this is 19 to 20 weeks, stage 1, yes, I should do it every week, but how is it going to help me? So after 1 week, if I see that the ductus venosus is abnormal, am I going to deliver it? No. So, we call them after 5 weeks. So, but the patient refused all genetic testing. They were called after 5 weeks at around 24 weeks, but they came at 26 weeks, 5 days. And then, of course, growth side had come down. There was reversal of flow in the umbilical artery. DV was normal, aortic isthmus was normal, 26 weeks, 5 days. So these are the findings that we have, but the ductus venosus is normal. So this is for me stage 3, but it is 26 weeks, 5 days. So we thought we will repeat the scan every 2 days, but the patient came directly after 5 days. that is the time when there was a reversal of diastolic flow in the aortic customers. Ductus venosus PI was greater than 95th centile, but there was still forward flow in diastole inductus venosus, and hence we asked for, that we will repeat a scan the next day, but the patient came after 2 days, and after 2 days, at 27 weeks 5 days, the reversal of A wave. Now this is stage 4. This is a stage when we would like to get this baby out. Maybe 2 days before also would have been right, but then yes, the patient also was very, very educated, and they wanted to pull on as much as possible. And then and this baby, a good 485-gram baby, was born, spent 40 days in an ICU and went home. But in early onset FGR, before 30 weeks, the critical endpoint should be a critical abnormality in the ductus venosus. And this lady had hypertension in the previous pregnancy, had from 27 weeks onwards, and had delivered at 34 weeks. So there is a history there. She was already on aspirin, NT was normal, uterine PI was high, 20-week scan was corresponding. So we asked for an early growth scan at around 27, 28 weeks, but she came at 29 weeks, 5 days. BP was 160 by 92, stage 1 findings, umbilical artery PI high, estimated fetal weight at the 5th centile. So we suggested follow-up after 1 week. Maternal blood pressure now was 162 by 94, pedal edema, albuminuria, but still stage 1. So follow-up after 1 week, 31 weeks, 6 days, still stage 1, but now there's maternal ascites, the BP is uncontrolled, 110 by 140. So, we keep saying, okay, Dopplers are stage 1, Doppler is stage 1, we will follow up. No, you have to take this call, because remember one thing, maternal condition supersedes everything. So that is the priority. Fetus is important, but maternal condition is more important than the fetal condition at that particular moment. Hence, that is where the role of pre-eclampsia comes in. And that is where our protocols as far as delivery decision making has to change. And thank you very much. I will end with this poem by unknown resident in Dublin, right, somewhere in 1800s. It was written that I am a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my doctor get me out at the right time, neither too premature nor too hypoxic, and definitely not acidotic. And with this, thank you very much. Thank you, Shilpa, for giving me an opportunity to be a part of this noble venture that you all have taken. From my side, any help required anytime, I will always be there, and please feel free to get in touch with me for any help required at any time. Thank you very much. And thank you, Dr. Rijo, also.
Thank you very much, Vimal sir, for your wonderful talk as usual. The impact of pre-eclampsia, the diagnosis of the implications on growth, the early FGR, absolutely, it was really, really wonderful how to go ahead with the stage-based protocols and everything. You explained it in a very, very lucid style. So thank you very much, sir. And I hope everyone will start following you and will be doing, as you explained that it's very easy to have just a BP apparatus. We can train our staff as radiologists. We only have to do the uterine artery Doppler. Once we train our staff, it becomes very easy to have the pre-eclampsia screening. Thank you very much, Vimal sir, for the same. Yeah.
Before we go on to the next session, I think questions we may be taking up at the end of both the sessions. And but before that, Vimal Sani sir, I just want to highlight one particular point. Preeclampsia, especially in the central part of India, we see quite a bit of preeclampsia, early preeclampsia, and a correlation with early FGS. Had a doubt whether our presumption that 75% of SGAs are 75% of small for date baby or small fetal weight less than 10% percentile are constitutional, and only 20% are uteroplastinal insufficiency. Where do we get that data from? Is it an Indian data or
no? It's not an Indian data. It's not an Indian data.
So sir, I seriously doubt that data.
Even I doubt.
If you look at if you look at Lalit's study in Guna in Madhya Pradesh, we see considerable number of early FGRs, early preeclampsias, and there is a significant correlation there. And numbers of early FGR and FGRs, even in the Samrakshan study that we did for 2 years, this is not constitutional babies are not just 75%. It is much lesser, and the true FGRs are more actually. So this is one area that we need to explore further.
I think a lot of them at first sight would be an SGA, but you do later on find that they see. We eventually have to use some criteria to whether to call them as FG, because the moment you call them as FGR, your surveillance will have to change. You will have to put them on a very, very close surveillance. So if you still find that your Dopplers are normal, see, there are so many questions in FGR which are still unanswered. And we need definitely we need our local this thing. There are so many times I find that yes, this appears to be constitutionally small, but we see them after 2 weeks and we find that the CPR has now changed, and that is an SGA has actually become an FGR. So these are all the changes that we do see, and so that's an international statistic, but even in Indian circumstances, there is an issue. One of the major issues is that is about the growth charts that we follow. See, our Indian growth charts that we follow actually undercall SGA. And if you follow headlock, you will overcall SGA in our Indian population. But then it is better to overcall SGA rather than undercall SGA. Because if you overcall SGA, at least you are going to do the Dopplers and you are going to at least pick up that subset which actually requires much closer surveillance there.
Yeah, I think we have to start on the premise that the Western data has got 75% small constitutional this thing and very less 20% FGR, because generally their FGR is less. It is not the case in India. India has got nearly 25 to 30% of FGRs. So that data, when we follow it, that maybe it is one area I think we need a lot of research with our own data and come to conclusions there. So thank you, Bimal Sani sir, for that wonderful lecture. You have taught us new insights, categorically stated some many facts that we have to put in use as far as Samrakshan is concerned. Thank you once again.